Hi, my name is Elizabeth Cook. I'm a pharmacy intern. A patient presented to the emergency department with a fever that has persisted for the past 2 days. Patient has stage 4 prostate cancer with metastases to the spine and hip. His third course of chemotherapy was completed 10 days ago with docetaxel 75 milligrams per liter squared for hormone refractory disease. The past 2 days he has had a fever of 38 degrees Celsius and is currently taking acetaminophen around the clock to avoid going to the emergency room. His highest reported fever at home was 39 degrees Celsius. The patient's blood pressure was labile and required 2 liters of normal saline to stabilize once in the emergency department. The patient has significant prior medical history, including the aforementioned stage 4 prostate cancer, external beam radiation, Hickman port, and DVT that occurred 6 months ago. His mother died of breast cancer and has no significant social history. The patient currently is febrile and nauseous. Patient's current temperature is 38.2 degrees Celsius. Blood pressure is 80 over 44. Respiratory rate is 22. He weighs 70 kilograms and is 6 foot 1 inch. He is positive for mucositis, limited bowel sounds, erythema, and streaking noted at the site of the Hickman port. He is suspected to have febrile neutropenia. His ANC is currently 300, and his hemoglobin is 10.5 grams per deciliter. His B1 is elevated at 57 milligrams per deciliter, and his serum creatinine is currently 6.04 milligrams per deciliter. His corrected calcium level is 12.1 milligrams. Phosphate is 2.2 milligrams. Based on this information, it is likely that the patient has experienced acute kidney injury and hypotension secondary to sepsis. The patient also has febrile neutropenia and hypophosphatemia secondary to the hypercalcemia of malignant phase. Empiric therapy was initiated for sepsis, and according to the NCCN guidelines, patient is a high risk, and therefore it is recommended to initiate meropenem 1 gram IV every 12 hours. It is also noted that moderate interaction with warfarin, so additional monitoring of the INR should be initiated at the start of antibiotics. For the vascular access, it is recommended to remove the catheter and culture the surgical wound. Adding vancomycin 15 milligrams per kilogram and therefore 1 gram IV every 48 hours for this patient should be initiated for 7 to 14 days. It is advised to monitor the vancotroph after the first dose to a target of 15 to 20 milligrams per deciliter. Follow up by repeating blood cultures to assess, evaluate for response and toxicities. It is not currently recommended to initiate vasopressors at this time as patient is hemodynamically stable. For the febrile neutropenia, docetaxel is greater than 20% risk of febrile neutropenia, and therefore it is recommended to pretreat. Since his ANC is 300, it is advised to give filgrastim 350 micrograms until the ANC is recovered at a level of greater than 1500. For the hypercalcemia, as previously stated, his corrected calcium level was 12.1 milligrams, and it is advised to initiate rapid infusion of normal saline 300 milliliters per hour until euvolemic, as well as furosemide 40 milligrams IV every 24 hours, and to start the furosemide only after adequate hydration. Thank you for taking my recommendations into consideration. I look forward to hearing from you.